the myth itself. Can it be cured? Will we ever cure it?
Well, I think that we're getting to the point where we understand the major effector cell, the cell that's involved is mast cells, to also an extent basophils, which are blood cells, cells in our bloodstream, but mast cells are tissue-based cells. And we know a lot about the different types of cells, and they're not all the same. They have different uh, chemicals inside them, one called tryptase, kimase tryptase. They look different. Some are in the skin, some are in mucosal surfaces, so they're different. And they have a whole array of receptors on their cell surface. And there are some receptors that when you target them and you block them, you can actually kill the mast cell and you can typically get rid of them. So we're at the point where we know how to get rid of mast cells. And the question is, will that cure hives? Most of the treatments we have now control hives. They get rid of them or improve them significantly, but they don't cure them. And that when you stop, in most studies, the hives will come back in many of these patients over time. Not again, let's not confuse that with going into remission. And that's not necessarily a cure. That's more of the natural progression of this condition, that it does, come and go over variable periods of time. But so I think that we're learning more about the pathogenesis of hives, and therefore we can target specific receptors that may actually turn off mast cells and be potentially curative, turn them off or reduce their numbers significantly. So this is what we're looking toward to do. Of course, every time we develop these treatments, we have to make sure that the safety and the efficacy is better than the side effects. And so that's always something we keep in mind.
Yeah. Yes, and that gives us all a lot of hope, Dr. Bernstein. I think you framed that very well. And the only thing I'll add on to there is that certainly where we see ourselves now versus 10 to 15 years ago, as a medical research and patient care, advocates in this arena, that we have a lot more, we're much closer, right? So the advancements are significant and they are exciting. So it's a good time.
The role of the clinician is extremely important, because if you don't characterize your patient with hives when they come into the office, and you just treat them all the same, and here, take some antihistamines and call me if they don't get better, you probably don't have a very good chance of really helping that patient long term. Of course, there will be a subset will respond to antihistamines and you'll never see them again. But the ones, though, that aren't responsive, they may have more complex, more difficult to treat hives. And they need to be better characterized. And we are starting to get to, because of the development of biologics, as Karen mentioned earlier, we now actually have some biomarkers that can make certain predictions. They're not ready necessarily to incorporate into guidelines, but they are useful tools for helping us better characterize patients. And so I think that that's what we refer to as phenotyping, characterizing patients to correlate with the underlying mechanism associated with hives in each of these individuals. And we know that, for instance, up to 50% of patients with chronic urticaria, chronic hives lasting longer than 6 weeks, might have autoimmunity. They might make antibodies against certain receptors on their mast cells. And these patients tend to be more challenging. And this is why we are developing these novel therapies that target different pathways that can treat these more difficult patients.
That's fascinating. That term is fascinating, and I must follow up on that. But before we move on, I do want to ask you, if we move toward turning off mast cells, are there other conditions that would help us to control that people with urticaria might also experience?
Well, certainly it can help patients, up to, a significant percentage, up to a third of patients with urticaria might have a condition called angioedema, which is soft tissue swelling. And again, we think about urticaria as affecting the epidermis, but when you get into the deeper dermis, that deeper into the skin, then there can be swelling, because what happens is blood vessels dilate, the cells lining the blood vessels separate, and fluid escapes, and it causes edema or swelling. And so angioedema is actually a sign of more severe hives, and sometimes more difficult to treat hives. And a significant percentage of patients have this in association with hives. So certainly that could be a benefit. There's other conditions where mast cells play a prominent role, where these therapies can be helpful. And, it could be any number of diseases, because mast cells are really ubiquitous and involved in a lot of different clinical conditions. We already know, for instance, in some of the newer biologics that have been developed and that might be approved in the future. Well, first of all, omalizumab, which is approved and already approved for asthma before it was approved for hives. So it was working in asthma, and it may, in part, through working through mast cells. The same can be said of another therapy called dupilumab, which is also approved for asthma and other disorders where mast cells play a role. And so I think that you're spot on when you talk about other conditions, other comorbid conditions associated with chronic urticaria, and how these therapies could be also helpful for these conditions. And so we'll learn more once if and when these drugs are approved, and we'll have some real-time experience in the clinic on using these things.